Thanks for joining me tonight. I am I'm Dr. Jones, I'm Matt Jones. I'm a a hand and upper extremity orthopedic surgeon at Columbia Orthopaedic Group. I've been here since 2013. I specialize kind of from the fingertips to the elbow. All of us orthopedic surgeons specialize in a body part. Um, the topic for tonight's webinar is common hand problems, primarily chronic things is what I like to focus on. And really, the inspiration for my topic tonight was when I decided to go into hand surgery. So, as orthopedic surgeons, we go through 4 years of medical school. We then do 4 years of college and 4 years of medical school, and then we do a 5-year orthopedic surgery residency. And then most of us go on to do a year-long fellowship. And that fellowship can be in a variety of surgical orthopedic surgical subspecialties. And I chose hand surgery. And when I chose hand surgery, I got a lot of questions from family members and friends who understandably didn't even know that that was a thing. And they said, well, what are you going to do as a hand surgeon? Are you just going to do carpal tunnel surgery all day? Because ultimately, that's the only diagnosis that they knew when it came to the hand. But interestingly, when it comes to hand surgery, there's a lot of different things that we treat, and that's part of the reason why I chose the specialty is the wide variety of things that we treat. A lot of the other orthopedic subspecialists, only focus on, one or two joints, or some of them really just do one or two procedures, which is great. It makes them highly efficient at what it is they do, and they do it very well. But the nice thing about hand surgery is there's a little bit more of a variety. We deal with bone problems, we deal with ligament problems, we deal with tendon problems, we deal with nerve problems, we deal with skin and soft tissue coverage. We deal with acute injuries like tendon lacerations, tendon cuts, saw injuries to the hand, um, biceps, triceps ruptures, those types of things. We deal with a variety of types of forearm, elbow, wrist, finger, hand fractures. But then we also deal with a wide variety of chronic things, arthritis type things, or tendonitis type things, overuse things. And then, of course, nerve decompression like carpal tunnel syndrome. So that's kind of why I chose it. And it's an interesting field. It's an ever-changing field. And it's an opportunity to really make a difference in people's lives because our hands are how we interact with the world. They're an extension of our brain. And so today's topic is going to focus mostly on the chronic things that I deal with as a hand surgeon. So hopefully you guys can all see my screen. I'm sharing it, and we're going to get started with the first slide. So the first slide, chronic hand ailments. The first thing we're going to talk about is carpal tunnel syndrome. We'll then talk about cubital tunnel syndrome. So everybody's heard of carpal tunnel syndrome. Not everybody knows what it is, but everybody's heard of it. Fewer people know of or have heard of something called cubital tunnel syndrome, and then trigger finger. And then after that, we'll talk about the Quervain tendonitis. And then the last thing we'll talk about is thumb CMC arthritis. All of these things are very common things. I was in the office today and I saw each one of these things multiple times. It's super common. So the first thing is carpal tunnel syndrome. So carpal tunnel syndrome is a nerve compression. And if you look over at that image on the right, that's a cross section of the wrist. Those little white things across the top, those are bones, carpal bones. And then if you look, they kind of form an arc or an arch over some black structures that you'll see there. That is the carpal tunnel. That is literally the tunnel that the tendons that move the fingers and the median nerve run through that tight tunnel. Carpal tunnel syndrome is where the pressure inside of that tunnel gets elevated for a variety of reasons. As on the screen would the slide indicates, things like diabetes can cause that, thyroid disorders, alcohol use, inflammatory arthritis like rheumatoid arthritis, amyloidosis, cigarette use, pregnancy, and a host of other things can cause pressure to be elevated within that tunnel, including occupational hazards and overuse injuries. We typically see it in people that are middle-aged. Occasionally, we'll see it in people that are a little bit younger or older. Slight female preponderance in carpal tunnel syndrome. The symptoms are going to be numbness in the hand, but not the entire hand. Again, if you look at that diagram over there to the right, that bluish purple area, that's the area that's impacted by carpal tunnel syndrome. The rest of the hand is not. And so what you'll get is numbness and tingling in the thumb, index, and middle fingers, part of the ring finger. Um, Patients tend to notice the symptoms more at night, and we think it's because of the way that we sleep. But other times that are really common are when driving, when using the telephone, using a blow dryer, squeezing, um, vibratory tools, anything that requires gripping or pressure in the kind of the palmar area right here. That's where the carpal tunnel is. Those can cause the symptoms. On exam, there's certain things that we do to try to examine it. One of those things is something called a Tinel's test, which is where we'll tap right here, and that taps on the median nerve as it goes through the tunnel. Usually the nerve is compressed. It's going to be very hypersensitive, and so lightly tapping that will cause sometimes an electrical shock that goes to the fingers. And in really severe cases, we'll see atrophy of the thenar muscles, which are the muscles right here, if you can see me up in the upper right-hand corner. These muscles here are called the thenar muscles. And with severe carpal tunnel syndrome, what can happen is that those muscles will atrophy and you can start to get clumsiness or difficulty with fine motor skills. And so history and physical are very important to diagnose carpal tunnel syndrome, but then also we typically like to get diagnostic testing. It's nerve conduction testing, and that helps kind of elucidate the picture. So how do we treat carpal tunnel syndrome? The first line treatment is night splinting and a brace, which you can kind of see in this on this slide as well. Any over-the-counter brace like that. And we typically recommend doing it at night because it seems to be, number one, that brace is pretty cumbersome to wear during the day, especially if you've got a job where you have to use your hands a lot, which most of us do. Additionally, we think that the brace works well at night because of the way we sleep. We tend to kind of curl our wrists one way or the other when we're sleeping, which kinks the nerve and increases the pressure in the tunnel. And so if you wear that brace at night and keep it in a neutral position, the wrist in a neutral position, it can rest that nerve. And sometimes if you do that at night regularly enough, sometimes it can actually make the daytime symptoms better. The other thing would be non-steroidal anti-inflammatory drugs, things like Aleve or ibuprofen. If you're able to take those can sometimes help. Steroid injection. A steroid injection into the carpal tunnel can be beneficial. What we think that it does is it takes the pressure down in that tunnel. So as I mentioned previously, there's multiple tendons that run through that tunnel. And if those tendons swell for any reason, it increases the pressure in the tunnel, and that's what squishes the nerve. And so the idea behind the steroid injection is to take that swelling down, which then decreases the pressure on the nerve and can make the symptoms go away. As the slide would indicate, most people get some relief from the injection, but it also tends to be temporary because whatever's causing that underlying swelling will likely come back. Not always, but likely will. For example, if you've got uncontrolled hypothyroidism, the shot might make the swelling go away for a while, but then it's going to come right back because the underlying problem is the hypothyroidism. That's just one example. So if those non-operative options fail, there's surgery that we can do for it. The surgery is a very successful surgery. It works great. It's also a pretty quick recovery. Certainly not as bad as it used to be maybe 20 years ago. So over here, if you're not squeamish, if you are, don't look. If you're not squeamish, there's a small picture in the right lower hand box there that shows what the incision looks like for carpal tunnel. It's relatively small. It's about 1.5 inches. It's right here in the kind of the palmar area of the hand. And essentially all we do is open up the roof of the tunnel, which takes the pressure. We cut through the ligament, not the bone, the ligament. We open it up nice and wide, and that takes the pressure off the nerve. So the next nerve compression is something called cubital tunnel syndrome. So fewer people have heard about cubital tunnel syndrome. That is nerve compression of the ulnar nerve. The ulnar nerve lives along the inside part of the elbow. So it's going to be this part right here is where the ulnar nerve lives. It's the funny, it's the funny bone nerve. And it's typically entrapped by several, usually about 3 little bands of tissue that cross over that nerve and compress it. It causes numbness and tingling in the other part of the hand, the part of the hand that we, if you'll remember on the previous slide, carpal tunnel primarily impacts these three fingers, impacts a little bit of the ring finger. Cubital tunnel is what impacts the pinky and then the other side of the ring finger. It's usually worse with elbow flexion, and the reason that we think that is that the nerve lives kind of along the inside, but also back part of the elbow. So it's like the skin. When the elbow's straight, the nerve is loose. When the elbow's bent, the nerve is tight. And so anytime that the elbow is in a prolonged flexed position, it's going to stretch that nerve and potentially cause the pinky to go numb. Occasionally, it's also due to something called ulnar nerve subluxation, or in this case, it will feel like a snapping that goes across the elbow there. When you move your arm back and forth, sometimes that nerve will kind of pop back and forth over this bony prominence here called the medial epicondyle. So in physical exam, we try to do the same thing we do with the median nerve at the wrist, is we tap right here along that ulnar nerve course, and if it elicits a shocking or a zinging feeling, then that can be a positive test for cubital tunnel. In severe cases, what it can also do is cause weakening of the muscles in the hand. There's muscles in between the bones of the hand here and on the sides, and those muscles are innervated by the ulnar nerve. And if that nerve is compressed severely for a very long time, it can cause those muscles to wither away. Those muscles are what we call the intrinsic muscles of the hand. They are responsible for fine motor skills. They're responsible in part for grip strength. And so if those muscles start to wither away, you can start to kind of have clumsiness with buttoning buttons or fine motor skills. Additionally, there's a couple tests that we look for here where it's hard to maybe grip a piece of paper between the thumb and index finger. Or sometimes it'll even cause the small finger to kind of drift away from the other fingers because the muscles that hold those fingers together are weak. And again, the same thing we do for this. History and physical are very important, but then also we typically will get nerve conduction studies like we do for carpal tunnel. It's also common, not uncommon, for carpal tunnel and cubital tunnel syndrome to occur at the same time. So for cubital tunnel, our options are a little more limited. There's no injection for it. Injections don't work for cubital tunnel syndrome. Some people may have some luck with a medial elbow pad or a night splint. The splint's kind of rigid. It keeps your elbow from moving. It can work. I even have had more luck, I think, with like taking a small hand towel from the bathroom, folding that in half and wrapping that around the elbow. And what that does is allows the elbow to move a little bit when you're sleeping rather than being rigidly straight. But it won't allow the elbow to fully bend, which stretches the nerve and irritates it. So sometimes by doing that at night, it can rest the nerve enough at night that maybe the nighttime symptoms are not so bad. But besides, basically that, the other option is kind of either living with it if it's mild, or if it's quite bothersome, surgery would be the option. And this diagram, this picture at the lower right-hand corner is the ulnar nerve along the inside part of the elbow. That's the incision for it's a little bit smaller than that, but it does show you the kind of the little bands of tissue there that we have to release that take the pressure off the nerve. Next condition is trigger finger. So this is not a nerve. The previous two things we've talked about were nerve conditions. This is not a nerve condition. This is actually a tendonitis. It is, if you look here in the picture that I've given you to look at here on the right side of the screen, essentially what it is there's the tendons that bend the fingers, that flex the fingers, are called the flexor tendons. And what they do is those tendons are kind of like ropes, and what they do is they run along the finger like this, and then there's a series of loops that those tendons run through. We call those loops pulleys. What happens with trigger finger, and we're not exactly sure why it happens, but it does tend to be more common in diabetics, people with rheumatoid arthritis. What happens is the tendon develops a little swelling or nodule in it. And that's what this diagram or this picture is indicating, is that tendon nodule. And what happens is that it gets stuck. Sometimes it gets stuck, it goes all the way through it, and it sticks down on this side, and you have a hard time getting it back through. Or sometimes it'll be so swollen that the finger won't bend at all because it's getting locked at that loop or that pulley, and it won't go through. And what it does is it really impacts the motion of the PIP joint more than anything, which is this joint here. And there's multiple stages to trigger finger. The first stage usually is where it's just painful but doesn't really lock or catch. The next is where it can kind of click a little bit. The third is where it will lock and it has to kind of and you have to kind of use your hand to unlock it. And then the fourth stage is where it'll lock and it just won't move at all. Um, and you don't necessarily go through those stages in sequence. In other words, you might start at stage four, or you may go from stage three back to stage one and back and forth. But those are kind of the different stages of trigger finger. How do we treat it? Well, so fortunately, trigger finger injections, so steroid injections for trigger finger are actually really successful. I would say in my experience, I would put the number at around 80% get relief with just a steroid injection done right in the office. And a lot of times that's the only treatment that you need. It can be a permanent fix. Unlike for arthritis and some other things where steroid shots aren't a permanent fix, they provide temporary relief. But in this case, trigger finger, just a simple steroid shot, 80% of the time will fix the problem permanently. Typically, the next shot, though, for example, if you're one of the few people for whom that have gotten one shot and then you get a second shot, usually that second shot's just not going to be as successful as the first. I mean, there are exceptions to that, but usually your first shot's the best. And it does seem, for whatever reason, we're not sure, those poor diabetics who seem to have issues with all sorts of things, don't seem to respond as well to steroid injections, and they also tend to get multiple trigger fingers if they get them. So more often than not, diabetics will end up needing surgical intervention. But the good news is that the surgery is not a big deal. The surgery is very straightforward. It's done under local anesthetic. It truly only takes about 5 minutes. The incision's maybe 3/4 of an inch. And the surgery is actually relatively simple. All we do is we make an incision through this area right here. For example, if I was doing the index finger, the incision would be just right here. It's maybe a 3/4 inch incision, and then all I do is release the loop. Just release that pulley. It's called the A1 pulley. And once we do that, then the finger can move freely. The nice thing about this procedure is it's very simple, and it also provides immediate relief. The recovery of the surgery is pretty brief. You've got a small incision you have to protect for maybe about 10 days. Then after that, you're good to go. The next chronic condition I'd like to talk about is something called the Quervains, stenosing tenosynovitis, or the Quervain's tendonitis. It's actually very similar to trigger finger, except it's at the wrist. And so where that is primarily the problem is over that picture there at the top right. There's an area there that I don't know if you can see my pointer, but it says the extensor retinaculum, and then there's an arrow that points to it. That's where the problem is. So that's going to be in this area right here is where de Quervain's is tender, and it's going to be sore enough that you can push directly on that area, and it's going to be tender. For example, carpal tunnel syndrome isn't one of those things that you can push on and make it hurt. Carpal tunnel syndrome is going to be more tingling in the fingers and more of a vague wrist pain that you just can't push on and make hurt. De Quervain's, if you push right there and you've got a raging case of de Quervain's, that's going to be very tender right there. And so it's more common in women. We're not exactly sure why. The literature does suggest that there's kind of two peaks. We do see it in men as well, but it just seems to be more common in women. But there's actually two peaks. There's one that's around the kind of the childbearing age for women, and then also maybe around the perimenopausal age. That's what the literature has shown. My experience has been, I also have seen it in maybe new caretakers. For example, a grandmother who's now taking care of a grandbaby on a regular basis. And so, one thought is it may be the way that you're holding the child more so than hormonal component, but there was thought that maybe there's a hormonal component to it as well. The symptoms are going to be pain, as in the picture at the very bottom of the screen. It's going to be that yellow area. What that diagram is demonstrating is something called the Finkelstein's test, which is where you put the thumb here, you make a fist, and you bring your wrist down like that. That causes pain in that yellow area, highlight area, then that's pretty classic for de Quervain's. So other things that could be similar is something called thumb CMC arthritis, and we're going to actually spend quite a bit of time talking about that because that's also very common. And I see it in my office a lot. And patients seem to sometimes be very surprised that it's not carpal tunnel or something else. So we're going to spend some time talking about CMC arthritis. But that can be pain in a similar location as de Quervain's. It's just slightly different. So de Quervain's is going to be more here, whereas thumb CMC is going to be more here. Only about an inch or so apart, but it's an important distinction. Another thing is called intersection syndrome. That's going to be in a slightly different location. That's going to be kind of right here on the wrist rather than right here. Again, only about an inch away, but it's actually a little bit higher up. It's kind of where my band is here, but it's only about an inch or two away from de Quervain's. But it can, and it's a similar phenomenon, but it's a lot less common than de Quervain's is. Other things would be scaphoid fractures, arthritis in the wrist. Those can be tender in that location as well. And so sometimes we'll get x-rays to try to rule that out. So de Quervain's is treated non-operatively, kind of the standard treatment here with most of these things. It's going to be anti-inflammatories, it's going to be splinting, and then a steroid injection as demonstrated here in this picture here. You can see it. It's an injection that goes directly into that inflamed area. And there's also a surgery that work if you're one of the ones that the injection does not work for. There's a surgery that works really well, and a lot like trigger finger, it's a pretty brief recovery, and it works great. But also like trigger finger, the steroid shots typically cure de Quervain's. In my experience, about 80% of the time. Okay, next is thumb CMC arthritis. This is a very common thing that I see. Again, see it more commonly in females, but I see it in men as well. It's a degenerative condition. It's arthritis, so typically going to see that in 40 or older. And quite honestly, 40 would even be young for it, but I see it occasionally. We're not exactly sure what causes it. It could be genetics. It could be previous trauma. Again, hormonal components may be part of this. Could also be caused by just generalized ligament laxity or joint laxity. But this x-ray here that you see on the right-hand side of the screen, that really ugly looking joint that's got a big bone spur there at the base of the thumb. Sorry. Go back. That is the CMC joint. It's the joint that's at the base of the thumb right here. The symptoms are typically going to be classically difficulty with gripping and pinching, opening jars, opening doors, sometimes shaking hands, squeezing, pinching, gripping is going to cause pain in that location. And some people who have really advanced arthritis can even have pain at rest. Examination is going to be pushing on that area to see if it hurts and trying to distinguish it from de Quervain's and some other things that may be in that general location. There's also something called a grind test, which is demonstrated by that tan image, where essentially you grab the thumb and kind of grind that joint to see if you feel grinding there. And frequently patients will have that. And then really bad osteoarthritis of that joint is going to cause subluxation, which essentially is where that joint's going to shift. So if a joint is a ball and cup, typically subluxation is going to be where that joint kind of shifts out of alignment because it's essentially worn out. X-rays we have to get X-rays to confirm this. And so non-operative treatment, again, kind of with the other things, anti-inflammatories, splinting, and steroid injections. Steroid injections for CMC arthritis are not curative. It's not something that's going to make it better permanently, but it is something that can provide substantial relief for a long time. Sometimes 3 to 6 months, maybe a year. So shots are definitely beneficial for CMC arthritis, especially if surgery is not something you're ready for. But ultimately, surgical reconstruction of that CMC joint is what we do, and it's a great procedure. It works wonderfully. It's a procedure that's been around for longer than I've been alive, and it works really well. It's a life-changing procedure. It will get rid of the pain. And the nice thing about thumb CMC surgery, it's called thumb CMC arthroplasty. The nice thing about it is when it's done, your thumb still moves and you can still use the thumb. A lot of times with the hand, when you have an arthritic joint, we have to do something called a fusion, which what happens is you then get rid of the joint, which means you get rid of the pain, but that also means the joint won't move anymore. And so you sacrifice motion for pain relief. The nice thing about this procedure is you don't have to do that. We can preserve the motion of the thumb and make the pain go away. So it's a win-win. So if you'll see here, there's multiple ways to treat it, but the mainstay, CMC joint fusions, pretty selectively done. The main thing is a CMC arthroplasty, and the core part of the CMC arthroplasty is removing a bone called the trapezium. And that's what the picture at the bottom right is identifying, is you'll see that there's the bone, there's several bones that has circle, but the one that's in that circle is the trapezium, and it's been taken out. And you kind of see it there on the right-hand side, taken out. And then it gets replaced by something. Typically, most surgeons will take a spare tendon that you have, and that's how it was originally described, is taking a tendon and doing something with it. Sometimes they'll just take it and ball it up and put it in there. It's called an anchovy. Other times we'll wrap it around other tendons to create kind of some support. And that's the way that I do it. And so this is the way that I do the procedure. So this is just a drawing that shows the trapezium being taken out. And so you see the space between the metacarpal and the scaphoid bone, the space here. And what I do is take a slip of the APL, which is the abductor pollicis longus, clip it, and then wrap it around the FCR, which is the flexor carpi radialis, and wrap it back and forth. And then essentially that creates a sling that holds up the metacarpal so it doesn't fall down in that space after the trapezium has been removed. And so I've got a case here that I'd like to share with you if you don't mind looking at some images. If you don't want to see intraoperative images here, they're going to be coming in the next few slides. You can look away. But these are preoperative x-rays of a patient with CMC arthritis. Again, I'm not sure if you can see my pointer, but right through here, this is the CMC joint. And this right here is the trapezium. And so this is a different view of it, but on the left-hand side. And then right here is the incision. So I tried to kind of line up the thumb with the actual thumb with the x-ray. So this is after incision's been made. Sorry, I should have warned you, but there's the incision. And then what you're seeing there that has the instrument, this instrument I'm holding in my hand here, I've got the brown glove on. That long straight instrument's called a freer, and what it's doing, the instrument just above that, the bone just above that is the trapezium. I've cleared off all the soft tissue at this point, and that's kind of a square shaped looking bone. That's the bone that I'm going to take out. And there it is. That's the trapezium after it's been taken out. What's interesting about this picture is that you can kind of see how shiny it is in the middle. It shouldn't be that way. That's what an arthritic bone looks like. What should be there should be white cartilage. It's kind of like what's on the end of a chicken bone. White, glistening, shiny white cartilage. This right here is actually kind of yellow, and essentially what it is, the cartilage is worn out to the point that that bone is almost like polished stone. It's shiny and it's hard. You can tap on it and it actually makes a noise like you're tapping on a stone. So now this is what it looks like after the trapezium has been removed. And so the bone, you can kind of see the metacarpal bone, just kind of the edge of the metacarpal bone. My freer, that same instrument that I had before, is underneath of a tendon called the FCR. That's the tendon I'm going to wrap the APL around. And so the tendon that you see right superficially, that's one of the slips of the APL. The beautiful thing about this procedure is that the APL is a muscle that has multiple tendon slips that come off of it. So we can take one of those slips and it doesn't compromise the function of the APL at all. So that's why I like the procedure. That, and it's done through just one incision. So I can clip that APL, I can wrap it around the FCR, then secure it back to the base of the metacarpal. And I believe that's what the next slide will show. The next slide shows me clipping that slip of the APL. And you can see all those other tendons that come off of it and how many spares there, how many extras there are. So really, I'm not compromising the function of the muscle at all by taking just that one slip. Now here it is after I've taken that slip and I've wrapped it around the FCR and I've secured it back to the base of the thumb metacarpal. And that's what holds that metacarpal up and keeps it from sliding down and bumping into the scaphoid. Then I will typically place a temporary metal pin from the thumb metacarpal into the index finger metacarpal to kind of help hold everything together. And this X-ray, intraoperative X-ray, shows that maintenance of space, which is what we're looking for. And that looks really good, and that's the way that we want it. And that's what it looks like when the surgery's done. There's the pin. I've bent the pin, I've clipped it, and I put that little white pin cap on it just to protect that sharp edge of the pin, and then close the incision. The patient then goes into a thumb spica splint, similar to what you see there. The patient's in that for 3 weeks. They can use the hand lightly during that period of time. They can eat, they can type, they can get dressed, those types of things. And then we give them a plastic glove to put over showers to keep it dry. And then when they come back to clinic, we'll typically transition over to a brace. We'll pull that pin that I put in. It's temporary. We'll pull that right in the office. And then they'll go into this brace and then do therapy. And then most patients do therapy for 1 to 2 months. The total recovery time for this procedure is anywhere from 6 to 10 weeks, depending on the patient and kind of how quickly they're able to work their way through therapy. But it's a great procedure. By the end of it, the thumb moves, it doesn't hurt, and all that pain you have with gripping and squeezing is gone. That's it. That's all I have. That's at least just the chronic things and there's other things. That's not by all means, that's not a comprehensive view at hand surgery, but that's at least probably the 5 most common chronic things that I see. I also treat a lot of acute things. And so things like broken fingers, broken wrists, tendon injuries. You cut a tendon, you can't move your finger. Also tendon injuries at the elbow, things like biceps tendon, triceps tendon injuries, all those types of things that we treat, forearm fractures. So a lot of acute things as well. But this is at least the most common chronic things. So at this point, I'm done with my presentation. If there are any questions, I would be happy to answer them.
Okay, Dr. Jones, we have one here. How can you tell the thumb CMC arthritis? Pain is where?
So if you can see my hand, the CMC joint's going to be right where my index finger is. It's through here, and then kind of the backside through here. So it's going to be at this joint that you kind of move when you move back and forth. This joint where my index finger is, that's where CMC pain is going to be.
Great. Next question. How quickly can I get in to see you for an issue?
Relatively quickly. So if you would like, I can provide you the number to call. If it's an urgent thing, we obviously have an urgent care where you can come in same day and be seen. And if it's something urgent, they will get you to me and I can take a look. I'm typically though in the office. In the office on Tuesdays, Thursdays, and Fridays. I operate on Mondays and Wednesdays. Right now, honestly, the summer's kind of a slow time, so you probably could get in to see me within a week or 2 if needed, and we can provide you that number. My secretary's number is 573-876-8149. Again, that's 573-876-8149. Her name is Rachel, and she might be able to get you in within the next week.
Great. You kind of answered this one, but would going to the ouch clinic be a first step?
So that's a good question. So to try to get in to see us, and us, I mean me and likely the other orthopedic surgeons at COG, there's a main number to call. It's 573-443-2402. And I can give you that number again, but it's on our website. What I'm getting at is when you call that main number, sometimes the people that work at that call center will be looking for the next news spot. And that news spot sometimes is actually booked out a ways. So if you can wait and for that new spot, for some doctors, it's maybe a week or 2. For some doctors, it might be a month or 2. If you can wait for that appointment, fine. If it's something that you can't wait for and you really want to be seen right away, I think the urgent care or ouch clinic is the best way to go because they can see you same day. Now, they may not be able to definitively treat you, okay? But they can at least see you, get imaging, get a diagnosis, and then they might be able to expedite getting you in to see one of us if needed.
Great. Another question. I just had trigger finger surgery 2 months ago, but it's still swollen and has some pain. What is good exercise to help this?
So that's a good question. One of those things that for me would be better if I could see it directly to give you the advice on that. Um, but your best bet if it's still swollen would be scar massage. So, for example, if it's my index finger and the incision's right here, a drop of vitamin E oil and some aggressive massage for about 10 or 15 minutes in that location can help with tenderness in that location. The swelling will typically go down with time, or there may be something else going on. So, if you're one of my patients, I'd be happy to see you back, or if you were treated by somebody else, I'd be happy to evaluate.
Great. A few more questions here. Can you have CNC thumb, ortho, and trigger finger repair at the same time on the same hand?
Yeah. So you can't always do multiple surgeries, but those two could be paired together. Yes.
Okay, great. What can be done short of joint fusions for arthritic finger joints?
Well, that's a whole different discussion because it depends on the finger joint. So what I mean is, if we're talking about not the thumb, if we're talking about the fingers, I'll use my index finger as an example. This finger is called the MP joint. This finger is called the PIP joint. This finger is called the DIP joint. And the treatment for those joints is different. It's not completely unlike the hip versus the knee versus the ankle. For example, this joint, we don't typically fuse. This joint can be replaced. This joint is kind of borderline on whether it gets fused or replaced. And we can kind of talk about the whys behind that and your activity level. So, for example, if you're really active, you're probably better off with a fusion than you are a joint replacement because the joint replacement will wear out with pinching and gripping. This joint, the DIP joint, is one that we typically will always fuse. There's no replacement for that. And the same general rules for all the other fingers. So typically MP can be replaced. PIP can either be fused or replaced depending on demands. And then the DIP joint's pretty much the only option there is fusion.
Great. Is there a good exercise for thumb CMC?
So is there a good exercise? I think that'd be a great question for a hand therapist, but it depends on what you're trying to accomplish. Okay, so the number one, the exercises aren't going to make the core problem go away. The core problem is the cartilage is worn out and you've got bone grinding on bone. So when you're talking about exercises, are you trying to do exercises to make the pain better, or are you trying to do exercises to improve grip strength and mobility? I think exercises are good at those two things. I think exercises are good at maybe improving strength and mobility and range of motion. I don't know that it's going to be overly helpful for relieving the pain. But if you're wanting to do exercises for strength, your best bet would be things like you can get resistant putty that you can work with to move the fingers and the thumb. You can get one of those squeezers that you can squeeze. You can get various types of foam balls that you can work to squeeze on. You can get rubber bands and wrap them around your fingers and spread the fingers out. Those are going to be things that will help strengthen the thumb and fingers. As far as range of motion of the thumb, there's 3 different joints of the thumb, 1, 2, 3. You can work on individual joints to get them moving. And stretching them back. You can bring the thumb across like this, bring the thumb out like that. There's a number of things, and then bring the thumb this direction and that direction. So those are some range of motion things, some strength things, but I don't know that those are going to alleviate arthritis-related pain.
Gotcha. Okay. What are some early warning signs that a hand or wrist issue moving from annoying to something I really need to see and get checked out?
Well, that's a good question. It depends specifically on what the problem is, and it's kind of hard to dispense specific medical advice without knowing what the diagnosis is. So having the diagnosis is important. But I think in general, if you're having a hand issue and the problem is deteriorating, if it's getting worse with time, I think it probably better just get it checked out to make sure it's not something that we need to catch early rather than later.
For sure. There's a few other comments about specific symptoms they're asking you for, but can you tell us once again, how to schedule an appointment with your office?
Yeah, so there's 2 numbers. The main number is 573-443-2402. And then my secretary's direct number is 573-876-8149. Her name is Rachel.
Great. And I think we're also, you can also text the office at 573-443-2402 as well. And one of the last questions before we wrap up here, Dr. Jones, that says, I live way south. Do you have other locations to see patients at?
Yeah. Actually, I go to I see patients at Lake Regional Hospital. Right now, it's just one Friday a month. I do surgeries in the morning, and then I see patients in the afternoon.
Very good. All right. Well, thank you very much, Dr. Jones. This is very informative.
Yeah,
Thank you.
thank you very much.
All right, thanks everybody for attending.